seeing everyone. You give it another minute or so to let everyone join. If you'd like, in the chat box, it'd be great if you could just drop where you're from so we know where you're calling in from. Yeah, New York, we have both coasts coming in today, which is nice. Got New York, California, South Carolina, New York. Wow, we have some good representation from New York. Dr. Sachdev, you gotta get some people from your coast here.
I know, but all the New Yorkers have like exclamation points, like such pride, you know, which is very true, the New Yorkers.
Well, it's getting late on our side, so I really applaud you guys for joining us today. Let's jump right in. Hi, everybody. Thank you so much for joining us today. We're hosting our next installment of our speaker series, and it's going to be all about PCOS and fertility. Before we dive into the topic at hand, let me quickly introduce myself. I'm Amy Devrania, the CEO and founder of UVA. We are an at-home fertility diagnostic that monitors two hormones, luteinizing hormone and progesterone, through your urine. We quantitatively measure these hormones to determine your most fertile days and confirm if you actually ovulated. Our test is completely personalized, so we don't wait for your hormones to reach some arbitrary threshold. We capture your baseline levels and then detect fluctuations by comparing to that. It's actually really great for women with PCOS because your baselines may be all over the place and UVA kind of learns what's going on with you. You simply pee on an UVA strip, which looks like this, scan it with your phone, and then you get your results in seconds. In addition, you don't have to mail your samples to a lab or visit a clinic to interpret results. We provide you with that lab grade quality result in the privacy of your own home within minutes. If you're interested in more information, you can check out our website at uva.life. And for our guests today, we are offering a 15% discount using the code PCOS event, and the code is valid until the end of the week. Just some quick housekeeping points. We are going to have a short presentation by our guest speakers, followed by a Q&A. But if you have any questions during the talk, please feel free to drop them in the chat box. Today, we're going to be doing a really deep dive into everything related to PCOS. And I'm thrilled to have Dr. Nidhee Sachdev from OC Fertility join us tonight. Dr. Nidhee Sachdev is a board-certified, fellowship-trained reproductive endocrinologist and infertility expert. Dr. Sachdev is passionate about providing individualized, collaborative patient care. She earned her medical degree at the University of California, Irvine School of Medicine. She has been published in numerous respected publications, receiving multiple teaching awards, and presented her research across the country. Dr. Sachdev is passionate about advocating for reproductive health and successful family building journeys for her patients. She sees patients at OC Fertility in Newport Beach, California, where she is a trusted expert in all areas of fertility, but is particularly interested in preservation such as egg, sperm, and embryo freezing, and how genetics play a role with IVF, patients with recurrent pregnancy loss. Dr. Sachdev, thank you so much for joining us here today, and I'll give you the floor.
Thank you, Amy. I'm really excited to be here, not only to educate all of you guys, but to talk about PCOS. UVA is an important product, and I've actually started talking to my patients more about it and having patients use it. And PCOS is a particularly important aspect of fertility that I think UVA might be a good product for. So, but without further ado, let's dive into the topic that we're here to talk about. So today we are going to talk about PCOS. Okay. All right, so the goal of today is we're going to talk about PCOS. What is it? Kind of the basics of how it works, and particularly how it might be involved or play a role in your fertility journey. So for starters, PCOS, what does it mean? It stands for polycystic ovarian syndrome, and it's actually quite prevalent. It affects about 8% of reproductive age women. Now, those numbers may not be entirely accurate because these are based on surveys. And so there could be more women or people out there who actually do fall into the category of PCOS, but maybe don't know enough to identify when they're having these symptoms to approach their doctor about it, or just maybe they just haven't been classified, because PCOS is very common. What's important to understand is it's not necessarily kind of a cut and dry or black or white, if you would say diagnosis. It's really considered to be on a spectrum. People can have a varying degree of symptoms of PCOS, and we use that to talk about where they fall on the spectrum and how to diagnose them. So there's a lot of different guidelines that we can use to make the diagnosis of PCOS. There's kind of three main categories that we use, and they're based upon different societies. And so there's one called the Endocrine Society, and there's something else called the Androgen Excess Society, as well as a third more commonly used called the Rotterdam criteria. Basically, what these are is that a group of experts got together and they used the information and data out there to kind of decide, based on their expert opinions, what the consensus should be, what guidelines we should use when to diagnose somebody with PCOS. And although the guidelines typically will involve kind of three basic categories of having menstrual irregularities, which could mean having too little menses or no menses at all, having an imbalance of androgens, which are considered to be male hormones, or having cystic appearing ovaries. Now, some of them will require certain things to be in there, and some will require having at least 2 or 3 of those to diagnose PCOS. But the bottom line is that it's really a syndrome due to an excess of androgens. Now, androgens are typically called male hormones, but these androgens are in both male and female, right? So the ovary needs to make these androgens in order to produce estrogen, and estrogen is pivotal for our menstrual cycles. Now, most commonly, well, you say, hey, in order to be diagnosed with PCOS, you need to meet 2 of 3 of the categories. So that could be having irregular menstrual cycles. It could be that you have imbalance of androgens, which might be like physical signs of it, or blood work that says you have elevated, or your ultrasound appearance. So if you have 2 of those 3, you'll fall into the category of PCOS. Now, we talked about how common PCOS is, but also many people will get the false diagnosis of PCOS. Particularly, I've had a lot of patients say, oh, you know, when I first got my period, I went to the doctor and they diagnosed me with PCOS. Now, diagnosing an adolescent with PCOS is actually really complicated. So it's not uncommon that a few years after we get our period to have irregular periods still, right? So a teenager might have a period every other month or every month. It just depends on when they got their period and how long it takes for their kind of pituitary endocrine axis to mature. But not only that, they're going to have often signs of excess androgens like acne or maybe hair growth, because, you know, as your body is turning on, as puberty is happening, you're going to have these symptoms. Additionally, a pivotal part of diagnosing somebody with PCOS often is ultrasound appearance of cystic ovaries. Well, really, what are those cysts? So every month we all have resting eggs, which we can see on ultrasound via something called a follicle. A follicle is a fluid-filled sac which holds our egg. As we ovulate, that follicle gets bigger and we release that egg. Now, when we do ultrasounds to evaluate someone's ovaries, we're looking at the ovaries and kind of seeing, okay, how many of these small resting follicles do they have, which contain their eggs? For PCOS, typically the diagnosis will be that you have 12 or more of these resting follicles on one or both ovary, and the volume of the ovary can be used to diagnose. But if somebody has a robust ovarian reserve, meaning they have lots of eggs, as we would expect to see in somebody younger, like in their teenage years, well, they would kind of automatically meet the criteria of PCOS by having irregular cycles. And if they had an ultrasound, we would expect to see 12 or more of these resting follicles or cysts on their ovaries because they just have a good ovarian reserve. So many people will say, oh yeah, I've been diagnosed with when I was younger. But I think part of it is kind of understanding, well, was that really the case? Or is that just kind of normal physiology of being an adolescent or a teenager? Another factor is patients who are overweight are kind of automatically diagnosed into the category of PCOS. Now, yes, a big part of PCOS in the diagnosis is having irregular menstrual cycles. But when somebody's overweight, the fat cells that we have are going to naturally convert the hormones that we have to excess estrogens. When you have an excess amount of estrogens, you often don't have a regular menstrual cycle. So you could have irregular menstrual cycles and it not be secondary to PCOS. And patients will often be diagnosed with PCOS just based upon being maybe overweight and having irregular cycles, but that may not be the case. As I mentioned, kind of an issue with adolescents is that someone who has a high ovarian reserve, meaning lots of eggs, you put the ultrasound in, boom, automatically they check off the box for having these cystic ovaries, but they just have a good egg count, which will yield lots of eggs. And then a really important aspect of PCOS is that it's actually considered to be a diagnosis of exclusion, meaning that you can really only say somebody has PCOS before checking off the boxes to make sure they don't have other things. So part of the evaluation of saying someone does or doesn't have PCOS is evaluating for other things such as thyroid irregularities or elevations in prolactin, or even some syndromes called congenital adrenal hyperplasia, which are genetic abnormalities in which our adrenal glands, which do make a lot of our steroids, including androgens, have an error in their pathway, and that the route from getting to make like cortisol and things that we need, it gets stopped someplace. We make excess androgens. And so it's really key that before you get labeled with a diagnosis of PCOS, that you try to see, okay, does it make sense to rule out some other things? Genetics plays an important role as well. So we know a lot of things kind of depend upon our family, but actually if your mom has PCOS, you have about a 35% risk of having PCOS yourself. And if you have a first degree relative like a sister, you have about a 40% risk of having PCOS. We often will see that PCOS is kind of tend to be more in certain ethnicities, right? So like South Asian women have a higher percentage of PCOS. Some of that could also be, you know, when talking about androgen excess and signs of having excess male hormones, some of that is physical characteristics like facial hair and such. And some of that could be cultural, because if you have darker hair, you know, you could appear as if you have more facial hair than somebody else who has lighter colored hair. And so it might be more prevalent, but we do notice it to be, yes, hereditary to some degree and in groups of different cultures. So symptoms. So a common one I just mentioned is menstrual irregularities. Well, how do you really know if you fall into that category? So that means having absent or infrequent menstrual cycles. So that means like less than 8 per year. So some patients will say, well, I'm getting a cycle every month. And then when I say, well, how often are you getting a period? And they look in their tracker, they're like, oh, it's actually like every 40 to 50 days. Well, if you do the math, you might actually fall into this category of having less than 8 cycles a year. Okay. What are the consequences of this? Well, one, you're going to have irregular bleeding sometimes, or heavy bleeding. If you're only getting a period every 3 months and it's unpredictable, you might have really heavy bleeding. And so at worst, some cases, patients may need to go to urgent care or the ER because they're having such heavy bleeding. The other aspect is that when you have, we call unopposed estrogens, meaning your body's making estrogens, but if you're not ovulating, your body is not producing a hormone called progesterone, which causes our uterine lining to be organized and shed in an organized way. If you are just not ovulating, your body is still producing estrogen. And even though you're not getting a period regularly, your uterine lining is still growing until it'll randomly start to shed. And so what happens is that if your uterine lining continues to grow kind of indefinitely, those cells can become abnormal, and it puts you at risk of having endometrial cancer or uterine cancer. So that's why it's really important that even if you're not trying to get pregnant, that you still have to be evaluated if you're not getting regular menstrual cycles. And then obviously, if you're not getting regular periods, you're likely not ovulating regularly, and that makes it hard to conceive. So it contributes to infertility. The other aspects that I mentioned are hormones, right? So excess androgens, male hormones like testosterone and such. So physical signs of having too many male symptoms could be hair growth. You might see in your face or certain parts of your body, acne, and actually an important one is hair loss. So you'll often see hair loss in the form of kind of like male temporal balding. It'll happen kind of up here in the forehead region. And then also, not everybody has to have symptoms of excess hair growth or acne, right? So because we know a lot of people have personal grooming preferences. So you might get waxed or laser, or your eyebrows done a lot, or whatever it may be. So then that might not be something that you're really able to identify. So another way is via blood work. Okay, so your doctor's able to test certain different androgens to see if your levels are elevated to put you into that category. Even though physically you don't have signs of excess hormones, you might on a biological level still. Another aspect is excess insulin. So for anybody who's kind of done the research about PCOS or talked to different doctors about PCOS, we know that diabetes and PCOS often go hand in hand. And the reason for that is because of insulin. So it's been really clearly identified that there is a strong correlation between androgen levels and insulin levels. Now, it's not really clear which one came first, the chicken or the egg. Is it that you have elevated androgens, so you therefore have elevated insulins? Or maybe you just have elevated insulins underlying, and that's causing you to have elevated androgens. It's hard to say which one contributes to what. Now, what is insulin and why does it matter? Well, because insulin helps control your blood glucose levels. And so it helps control your blood glucose levels by breaking down your glucose from your stores and by taking the glucose that's excess there and putting it into your stores. It also helps regulate your fat storage and breaking down fats as needed. So why is this important? Well, because PCOS with the elevated insulin levels puts patients at risk of having glucose intolerance, which leads to potentially diabetes and other metabolic issues like cardiovascular disease and elevated cholesterol. And that's really important. Why? Because diabetes puts you at risk of not only long-term health issues, but it also puts you at risk of a complicated pregnancy. So for anybody who's diagnosed with PCOS, part of the evaluation should be screening for diabetes. You can do that with blood work. You can also actually do it with something called the 2-hour glucose tolerance test. It's not everyone's favorite test because it's kind of time consuming. You have to drink kind of this really sweet drink, which is a load of glucose, and you get your blood tested an hour and 2 hours later to assess, is your body responding to this load of glucose well and producing the insulin appropriately? So for my patients, depending upon what evaluation they've had beforehand, I recommend that they get that prior to even getting pregnant, because although they may not have signs of diabetes, if that's elevated, we want them to be treated and have things under control before they get pregnant to have a healthier pregnancy. Another aspect is that many patients will say that they have a hard time losing weight, patients who have PCOS. They'll say, well, I have friends who weigh the same as me and they do the same thing I do, but they lose weight and I don't. Why is that? Part of that has to do with the excess insulin, because that regulates how your fat is stored and how your fat is broken down. Another huge part of PCOS is the mental health aspects. Depression, anxiety, and bipolar disorder are associated with PCOS. And that's really important. I think it's very often overlooked. So yes, it's the symptoms that are associated with it, having maybe the signs of the excess androgens or having menstrual irregularity, and obviously infertility is associated with it. But biochemically, there has been some associations with your neurotransmitters being different, which are predispose patients with PCOS to have higher degrees of depression, anxiety, and bipolar. So I think that's a really important part of the puzzle. And I think that if you have PCOS and you have signs of mental health issues, that seeking counseling from somebody is important. But not only that, getting your PCOS under control is probably going to be, significantly positively a contributor to your mental health issues. So now the main question is, how does it really affect your fertility if you have PCOS? The big problem is that it might affect your ovulation, right? And so if it affects your ovulation, it likely affects your fertile window. And then you might have a harder time trying to figure out when to try to conceive. Or more importantly, you might have fewer overall attempts per year. If you're getting a 50-day cycle, whereas somebody without PCOS is getting a 28-day cycle, we essentially have half the times per year to try to conceive versus somebody who has a shorter cycle. And that's important. So why does this happen? So I think in order to understand that, or to understand how to track your cycles, which is important for PCOS, is understanding the menstrual cycle and how it works. So here you can see in this diagram, there's two basic phases to the menstrual cycle. There's the first half, which we call the follicular phase, and the second half, which we call the luteal phase. Now for everybody, the luteal phase is the part after you ovulate. It's driven by a hormone called progesterone. And for the most part, regardless of how long your menstrual cycles are, whether they're 28 days or 48 days, the luteal phase is going to be around the same, on average 14 days, typically 12 to 14 days. So what that means, if that part is constant, the variable part is the follicular phase. So somebody who has a longer menstrual cycle, their follicular phase is going to be longer. And why does that really matter? Ultimately, it means it takes you longer to grow your egg and to ovulate it than it does somebody who has a shorter cycle. And that's where your ovulation predictor kits come in. Because if you have a cycle that's 20 days longer than your friend, well, your friend is going to start testing earlier and see that positive on her kit 20 days before you, right? Whereas if you have a longer cycle, you need to start testing probably later or for longer to catch your window. The problem with PCOS is that your baseline level of the hormone that we're checking to test your surge is called LH. Your baseline level is going to be at baseline elevated than somebody without PCOS. So that's where Amy was talking about how UVA is helpful, where UVA will take your levels and give you a numerical value and compare it to your own baseline. to give you an individualized response to say, hey, for you, it's elevated. Whereas if you were to use another ovulation predictor kit, it has its own threshold. And that threshold is going to be at a certain number. Let's say it's 10. So for somebody, if their baseline is 6 and then they start to surge and it's 20, boom, they get a happy face, they know I'm surging. But if your baseline is 14 and it triggers at 10, well, you're going to constantly have a positive and you're never going to know when you're surging. So that's what makes PCOS lead to infertility, in that it makes figuring out when to try to have sex or when to start using ovulation predictor kits complicated. And it makes just the fact of using those ovulation predictor kits complicated. But what patients say is that, well, what if I have a 40-day cycle and I can figure it out and I can track it and I have sex at the right time? Does that mean I'm less likely to get pregnant? No, right? If you can find your fertile window and get pregnant, you still have a good chance. But just overall, you have fewer chances per year than somebody who has a 28-day cycle. But if you track it for 3 to 6 months and you can time when to have intercourse, and you have a good shot. And I think that's important. So not everybody who has PCOS automatically needs fertility treatment. Sometimes you need guidance on how to track your cycles and how to follow things and to make sure there aren't any other underlying issues, but it doesn't automatically mean that you need treatment. So I kind of touched on this. Why do the ovulation predictor kits not work well? Well, they're used to detect a rise in LH, which we call the surge. Okay, that LH is produced by our body, which signals our ovary to say, hey, release the egg. And that's what your ovulation predictor kit is looking for. Okay, you're peeing on it every day, and you're waiting until it gets positive. And somebody with PCOS, your LH is elevated. Why is the LH elevated? Well, the LH is what sends the signals to make the androgen. So it's all part of the same process. Because we have elevated androgens, we'll have elevated of the LH. And so a big part of it is having a false positive, is triggering the ovulation predictor kits, and then also testing at the wrong times or not testing for long enough if you have a longer cycle. So now the question is, well, how do we overcome these issues? A big part of PCOS treatment is lifestyle, diet, and exercise, which is hard because it can be discouraging. As I mentioned, patients will say, hey, I have a hard time losing weight, and I know I need to lose weight to kind of help get my PCOS under control. Well, part of it is that by exercising and by changing lifestyle stuff, we're going to control your glucose levels within your blood, and you're going to overall affect your insulin levels. And that overall is going to lower your androgens and restore your hormonal imbalance. That's going to help decrease your risk of diabetes, and it's going to help regulate your menstrual cycles. Now, it's been shown that if somebody who's overweight and has irregular cycles, if they can lower their overall weight by about 5%, that in itself should resume your normal menses. Now, for some people, that's not easy. And so I always counsel patients, I say, well, don't focus on the weight. I don't care if you weigh this much and at the end of 3 months, you weigh this much, because studies have shown that just the sheer act of increasing your physical activity can actually decrease your overall insulin levels. So you're making positive changes to your PCOS, which is overall going to help your health and increase your fertility. Now, medications. What are medications that we can give to help with PCOS? And a common one that we often hear about is metformin. So metformin is actually a medication that we give to diabetics. It acts to decrease our overall blood glucose levels. It does that by decreasing the amount of glucose that's made and by increasing the effectiveness of the insulin we have in our body to help it to work better, to lower our blood glucose. So studies have shown that if they took patients with PCOS and they said, they gave some patients with PCOS who were not ovulating a placebo pill, and they gave some patients with PCOS who were not ovulating metformin, they showed that after about 3 months, the patients with PCOS started to resume their ovulatory cycles. Now, what they found is that it wasn't the metformin alone, it was the metformin combined with diet and exercise that really helped resume their menstrual cycles. So it's hard to say if it's a metformin on its own that did all the work, but really that diet and exercise in conjunction with things is going to make positive effects. So if you have PCOS and you're not ovulating and you're having issues with infertility, I think talking to your doctor about metformin is important, but understanding that, in what role it's going to play and how it's going to help you. An important thing about metformin is that it often has side effects that people aren't fans of, particularly GI side effects like diarrhea. So it takes time to normalize for people to get used to it, but it can have significant side effects. So really trying to figure out if it's right for you is an important discussion with your doctor. Now, the crux of fertility treatment for patients with PCOS is helping to get you to ovulate, right? So how do we do that? There's oral medications we can give, like something called Clomid or Letrozole, also called Femara. They basically get your brain to think that you're not growing an egg and to get you to grow an egg, right? To induce an ovulatory cycle. Even for people who are ovulating every 40 days, it can help by getting that to happen in a shorter period of time, to get you to have more frequent menstrual cycles, to get you to be able to attempt more frequently than every 40 days. Now, when they looked at patients with PCOS and they compared giving Clomid versus Femara, they actually found that the outcomes were a little bit better when we gave Femara or Letrozole versus Clomid, which is why for PCOS patients, we tend to give Letrozole to help induce ovulation over Clomid. It doesn't mean that Clomid won't work, but Femara might have a better outcome. Now, the problem is that Clomid is FDA approved to use for ovulation induction, while Femara isn't. So a detailed discussion with your doctor about the pros and cons of both is important. Just because you take these medications, it doesn't mean you have to have something called an IUI or intrauterine insemination. Now, if the sperm count's appropriate, there's no difficulty having intercourse, no pain or discomfort or any sexual dysfunction on the male side. If the primary issue is getting you to ovulate, taking the medication without an IUI is a fair option. Oftentimes patients will choose to have the IUI as well, but it doesn't mean you have to if the primary issue is you're not ovulating. And then the other aspect is the injectable medications, right? So there are some patients who don't ovulate and we give them the oral medication and they don't respond, even despite kind of trying different things and by going up on the dose. There's other things you can do by stopping, by maybe taking metformin for a little bit and then trying the medication or trying other medications. But if the oral medications aren't work, we have injectable medications that should work. They're the same medications we give in IVF, but a much smaller dose. The downside to all of these medications really, but more so with the injections, is that oftentimes when the goal is to grow at least one egg, you might grow multiple. And although that sounds like a great option because you have more targets for the sperm, the downside is that it really increases your risk of multiples, meaning twins or triplets. And the ultimate goal is for you to have a healthy live birth. And when we increase the number of pregnancies, the number of babies, twins or triplets, that really complicates the pregnancy. So sometimes I kind of refer to Goldilocks when talking about PCOS patients, because sometimes the oral medications aren't working. And with the injectable medications, it's almost hard to find that balance of what's just right, growing a follicle, but not having too much. And that's where IVF comes in, because sometimes you're kind of stuck between the lesser invasive options are giving you not enough or too much to do it safely. Now with IVF, the goal is we give injectable medications to grow multiple eggs. We take them out of your body via a procedure called the egg retrieval. We fertilize it with sperm and we make multiple embryos. And then we're able to take the embryos and introduce them to the uterus to transfer them one at a time. So this is an option that we often will give to patients because it can effectively help you get pregnant if you're not ovulating, but really significantly decrease your risk of having multiples. Now, again, not everybody who has PCOS has to do IVF, but sometimes if you're in that Goldilocks area, IVF is a way to do it a little bit more safely. And then kind of just to round out the topic, there's long-term health risks associated with PCOS, which is important, right? So metabolic syndrome is a constellation of things in which you have high blood pressure, increased cholesterol, and increased risk of diabetes, as well as kind of physical manifestations of being overweight. That's important because that really puts you at a higher risk of cardiovascular disease and stroke when you get older. As we mentioned, PCOS puts you at a higher risk of diabetes. And so when you have the diagnosis, it's important to kind of have an evaluation to make sure you don't have diabetes or pre-diabetes right now. If you are looking to get pregnant when you are pregnant, oftentimes patient will be tested for gestational diabetes earlier in their pregnancy, as well as the standard time later on. And just know if you're not diabetic now, you have a higher percentage chance of being diabetic as you get older. So just having a primary care doctor and keeping up with your overall health maintenance and kind of encouraging yourself to live a healthier lifestyle with diet and exercise, even if you're well beyond the time of when you're having menstrual irregularities and such. And then obviously depression and anxiety is a big part of PCOS. And so those can have long-term health repercussions as well. So I kind of focused, so that was the basics of what I talked about. I kind of focused, it was a little bit more laser focused on trying to get pregnant. But I think an important aspect of understanding the process is when talking about PCOS, we're talking about effectively having irregular cycles or having too many androgens. And when patients often come to us, they may have complaints or symptoms of having excess androgens. But if the primary goal is trying to get pregnant, then the treatments that we have we can't do anything about the excess androgens, because what we can do to treat the excess androgens or the male hormones keeps you from getting pregnant. And the other aspects are that some patients will say, well, no, my goal is to really focus on getting my menstrual cycles in control or getting the androgens in control. Then we have other things to do. Then we can actually put you on the birth control pill, which is actually the first line method for you having signs or symptoms of excess androgens like acne or hair growth. And there's other medications that you can take that will help control that. But it's important to know that if that is the route that you're going, but you later on are getting ready to start a family, to know that it might make sense to have an effective form of contraception while taking that to prevent pregnancy. Because if you were to get pregnant while taking those hormone blocker medications, it could potentially have a negative effect on a male fetus. Okay. Hopefully that was just like a little summary of PCOS. Hopefully that kind of jump-started a few questions.
We got a bunch of questions during at sign up, but thank you so much, Dr. Sachdev. If you guys have any questions, feel free to drop them in the chat box. I'd love to kick off the questions with one that I personally had. So I went through a horrible ordeal of being misdiagnosed with PCOS. And it's because I had all the symptoms that you listed. I had acne because I had just come out of college. I had gained a little bit of weight. I was pre-med, so obviously I gained some weight. And I'm Indian, so I had a lot of facial hair that was dark. And I was misdiagnosed, put on metformin, and I felt like it wasn't right for me, but I didn't know how to advocate for myself and ask my doctor I didn't know what questions to ask. So what advice would you have for someone like me that is going through this, and like, how can I better advocate for myself?
That's a good question. So I think the key is, when going to a doctor, right? I think understanding what your goals are. For some patients, it's saying, I have these symptoms, but my main thing is my irregular periods, right? That is my goal. Because for you, when you were put on metformin to manage your irregular cycles, you probably had a lot of side effects from it. You may not have had signs of diabetes, and that may not have been the right thing for you at that time. Whereas other things could have been, if your primary issue was your irregular cycles, you could have been put on something else to help with that, or kind of been counseled differently, right? And for some people, let's say you, like in your case, right? Let's say you had those symptoms, but you just weren't getting periods. What you could do is kind of work on the other aspects of life, like the lifestyle changes. And you don't necessarily need to have a period every month, but you just need to make sure you're having a period somewhat, at some regular intervals. So sometimes we'll give patients something called Provera to have a withdrawal bleed, which keeps you from increasing your risk factors from having a precancer, but doesn't make you go on the birth control pill if you don't want to go on the birth control pill, or have you start a medication to induce having a regular ovulatory cycles that gives you medication. So I think the best way to advocate for yourself, I would say, is to kind of have in your mind, like, what are your goals for your discussion with your doctor and for your own treatment outcomes. So that way you can focus on that. So you don't maybe get started on something that maybe you weren't interested in getting started on.
Thank you. A related question is from one of our guests here. I have not been diagnosed with PCOS, but have all the symptoms. One, what questions should I ask my doctor or OB/GYN? And two, what actions could I take to help improve trying to conceive naturally?
So, I hope that you have somebody that you can talk to, that you have a doctor you feel comfortable talking to about your symptoms. Because I know for some people, when talking about, even if you feel comfortable with your doctor, it's a little hard to say, oh, I'm having acne or I'm having facial hair and things of that sort. So I hope that you feel comfortable with whoever you're going to see to talk about your symptoms. So, I mean, I think the important thing to talk to them about is what your symptoms are, right? And what we can do to help with those particular symptoms. So like I said, is that, if you're talking about possibly conceiving naturally, some of the things that they could do to help with those symptoms are going to be counterintuitive or productive to conceiving. So the best thing that you can do is, if you're not already, is work on diet and lifestyle. And a lot of patients say, well, I already eat well and I exercise. So I would say, let's think about how you exercise, right? If you're primarily doing cardio, then I would consider doing some weights, not to build muscle, but just trying to attack the way that we can lower your insulin levels and your blood glucose in a different way. Not trying to say, hey, you're not doing enough, but trying to say, hey, let's take what you're doing and try to focus it in a different way to try to exhaust different ways that we can help with your PCOS.
Another question is, I'm hoping to learn more about the different types of PCOS and how to tell which one I may have.
So I think that there are different approaches to PCOS, and some may categorize them as saying, maybe PCOS after the birth control pill or inflammatory PCOS. And so it's not traditionally thought to say, let's categorize somebody as to one or the other, but to maybe kind of think about their overall picture. Right. So I think that's important. So typically, as a reproductive endocrinologist, I don't categorize people into type 1, 2, 3, or 4, or, A, B, C, and D. I try to think, okay, what is going on? What is the overall picture? Is there any signs of overt glucose intolerance or insulin resistance? If that is a big part of their PCOS, then we start to focus on that. For some people, they are not overweight. They exercise a lot and they're having regular cycles, right? And so then we start to think, okay, but they're not getting pregnant. What can we do to overcome their fertility issues and to see what we can do to help? So I think kind of the same answer to the other question is not necessarily what bracket do you find or what are the different categories, what particular aspects of PCOS are affecting you and how can we overcome that?
I have several more questions, but if you have any others, please feel free to drop them in the chat box. We have ample time to answer them. Another question is, what supplements would you recommend for a woman who has PCOS and is trying to conceive?
So supplements are always a big topic. And I think part of it comes from wanting to have some control. What can we do to help? Supplements have shown that they may help, and nothing has really been shown that it 100% definitely will. But specifically for PCOS, the ones that I recommend are like myo-inositol or CoQ10. Those are the more common ones that I recommend. And so, but
sorry, I was going to say, could you explain what those are and why you would recommend those?
Yeah, so myo-inositol and CoQ10 are ones that help with kind of the energy powerhouse of the cell. So the thought is that by taking those, you can kind of help the eggs work a little bit more effectively or efficiently. And it can kind of help overcome some of the particular quality aspects you might have associated with PCOS.
Would you recommend any of these supplements if you have very low progesterone?
I don't think that those supplements in particular are going to affect the progesterone level. If the progesterone levels are low, it probably has something to do with the way that the ovary is functioning. And so taking a progesterone supplementation after you ovulate is likely going to be the best way to overcome that.
And the last question I have here is, how can I ovulate naturally if I suspect that I have PCOS?
So I would say the best way is, if you're not ovulating at all, to try to figure out, okay, what's going on? Is it that, do you really have the diagnosis of PCOS? If you think there is room to improve your lifestyle, that's the number one goal. So generally recommend physical activity, 30 minutes a day, if you can, up to 5 days a week. And if you're doing like strenuous activity or really vigorous activity, 75 minutes a week would suffice. So I would say that would be the first thing to do. That's and then also thinking about what you're eating, right? Having a well-balanced diet. Obviously, when patients are concerned about diabetes, they think they have to kind of go keto or stop having any carbs. And that's not necessarily the best way to do it. If that works for you, that's great. But I think just having a more well-balanced diet, incorporating proteins to counteract the carbs, is going to be important. But from a natural standpoint, it's going to be just diet and lifestyle.
I think one of the big pain points that I experience with being a patient is I never know what symptoms my doctor cares about. So we're talking about excess facial hair, acne, all these things that we kind of just deal with because you've been going through it for however many months or years, and you don't think of it as a symptom of something deeper that's going on. So I guess what advice would you have for a woman who's kind of navigate all of this, and we go through so many changes throughout our life? So how do you kind of figure out what's important and what's not?
Well, I mean, that's a good question, but I think that's a really personal question, right? So what's important? I mean, from a medical standpoint, there's certain things that maybe you don't realize. There's a darkening of the skin. We call it acanthosis nigricans, which is a sign of insulin resistance. So you might see it kind of in different parts of your belly or on your neck or over here by your shoulders. That is an important physical characteristic to me, because that to me says, okay, there's signs of insulin resistance. We need to monitor this and we need to treat you. So those things, some kind of different skin features like skin tags and things of that sort are associated with insulin resistance. But I think, I'll have patients who will present with signs of facial hair that's bothersome to them. And, when trying to be objective and see from one to the other, to me, it doesn't look any more significant than somebody else's. But to them, if that's bothersome, right? And there is a fine line between saying, okay, that's bothersome to you, let me give you medication. So you balance it out to say, is it really elevated or is this really considered? So there are different scales that we can use to kind of measure, okay, hair growth here and there. But again, it's a little bit harder to do in the age when everyone has different grooming regimens that they do. So, but I think the ultimate bottom line is what's important to you and what's affecting your quality of life.
Absolutely. So one thing that we've gotten a lot of really good feedback about from the UVA's platform is, aside from just measuring your hormones, we actually allow you to track up to 35 things. That can be hair, acne, if you have oily hair, what your skin type is, and all these things that we actually share with the clinician. So if you're not sure if it's important, we take care of all of that for you, and then the doctor actually has all the information you need.
Yeah. That's actually really helpful because, it's not uncommon that patients will present with a symptom. And, when I ask more clarifying questions about it, they'll say, oh, I'm not sure. So I often will tell patients to keep a log of things, especially if you kind of have a bunch of different nondescript things that you're not sure how to describe, keep a log. And so that's really helpful because you have the ability to keep a log right there. And then that kind of compiles all the data.
Do you feel like the fact that depression and mental health is such a big component to PCOS, it has to do with the symptoms that women are having to deal with, or is it more molecular than that?
I think it's both. I think a lot of it is molecular. I think it's, clearly we know that the physiology is different, right? Like we see it by just people trying to lose weight. The physiology is different. So I do think there's a big molecular component to it, but the treatment for it is also the same things that can help with PCOS is exercise, is, mindfulness, yoga, things of that sort that has been shown that it can help with it. So it all ultimately is kind of helping to treat the same underlying pathophysiology. But yeah, I don't think it's just the symptoms. I think it can be exacerbated by the symptoms, but I do think it's molecular as well.
You guys have any questions for Dr. Sachdev? Because we have her here, and I think this is really informative for everybody. You can feel free to ask live or drop it in the chat, whatever you're comfortable with.
Hi, everyone. Dr. Sachdev, I just wanted to say, I thought this was so comprehensive, and I have PCOS. I went through fertility treatments, and I'm in mental health, and I'm so happy to hear that you spoke about the importance of mental health with PCOS. I think that's something that's often overlooked. And so I'm so happy to hear that you, as a reproductive endocrinologist, realize that and take that into account when working with patients, since I often get patients who are not living their best quality of life and they don't understand the link. So I'm really happy to hear that you touched upon that and you understand it. I think it's so important.
It is, yeah. And I think what people don't get is that it's a whole picture, right? When talking about even just trying to get pregnant, right? I always say it's about putting your best foot forward to feel like you're doing your best. And if you're overlooking your mental health, then that you're not going to be in the best place that you could be to try to get pregnant. So I think we're not just treating the uterus or the ovaries, we're treating the whole person. And I think that's important to evaluate. And I think people often just think like, oh, they're having a hard time getting pregnant. That's why they're feeling this way. But there's a lot more to it than just that.
Sorry.
No worries.
Does anybody have any other questions?
So I would say that one thing to consider for PCOS when doing fertility treatment is that, like I said, kind of the Goldilocks, not having enough with the lesser invasive options, or with the shots having too much, going to IVF. So patients who have PCOS who end up doing IVF, I think the initial thought is saying, well, I have a lot of eggs. I'm going to get a lot of embryos and it's going to be a slam dunk. But we have found that it's not just the number of eggs that you have, it also does affect the quality of the eggs too. So whereas growing an egg and ovulating and timing when to have sex is important, and that might be a big hurdle to many people, sometimes the quality of the eggs, that's kind of intangible, it is affected by PCOS. So it's not necessarily that everybody with PCOS, it's a slam dunk for IVF. There can be some hurdles, and age is affected in that too. But we're seeing that there's more to the egg quality with PCOS as well, which is important, which I think that patients often don't fully understand when going into treatment.
That's a great point. And that's a really difficult thing to, I think, monitor until you're kind of in the weeds of treatment.
Yeah, but which is why I always tell patients that, because I think patients are like, look, I'm not ovulating, that's fine. Let's just do IVF, you'll help me to ovulate. And so depending, everyone's different, but if I have patients that I think can genuinely work on lifestyle things, then I'll say, look, IVF is no big deal. It's a big deal. And you have a good chance at having a successful outcome, but let's just put the brakes on it for like 2 months or so, work on these things and then do it, because then we're going to optimize your outcome. Obviously, everyone's different. Some people don't have as much time to take 2 months off, but if patients, especially the younger ones who aren't ovulating, I emphasize that because I think that really helps with the outcomes, and it gets you ready and helps your pregnancy outcomes when we do the transfer as well.
Well, Dr. Sachdev, this is so, oh, sorry, does somebody have a question?
Yes, I wanted to ask more about the genetic component because I'm the only person in my family that has PCOS. No one else does. All the women in my family have endometriosis instead, and most of them have hysterectomy. So I don't even know how I ended up with it, if genetic plays a part. I know my family there's a lot of people that have diabetes. Both of my parents have type 2. But I'm trying to figure out, like, if my genetics played some part of it, how would it have done so? Because when we do get pregnant and we do have a baby, I don't want to pass that on to our daughter so that she's in the same predicament that I'm in now.
That is a good question. And that's one it's hard, right? Because there's nothing that we can truly do to say that you won't pass it on. Right. But if you look at the link, you talked about your mom and your dad having type 2 diabetes. How old were they when they were diagnosed?
My mom is, I think, 62, and she was diagnosed maybe 5 years ago, and
Okay.
my dad probably 3.
Okay. So, I mean, they were diagnosed when they were older, so that's not uncommon. So, I mean, it's hard to say. So, I mean, one, something is going to occur from every disease that's genetically predisposed is going to start someplace, right? And I think some of it is also environmental, right? We're living life in a different way than, maybe the women in your family lived in other ways. And so it's possible that there was some component of PCOS that maybe they had, but it was kind of masked or overridden by their endometriosis, or maybe you are the first within your lineage or your generation to have it. I think what's key is that, if you have it, to being able to identify it. And if your daughters have it, then being able to help identify it in them. It's not something that we can say, hey, we can limit it from happening to your future offspring, if it is, but it's also not a one-to-one correlation as well. It's been shown that in families, there could be an effect to it, and that you have a higher risk if your mom has it or your sister has it, but it's not that, everybody who has it will pass it on to your daughter.
Got it. Thank you.
Yeah.
I think some Jeopardy music. All right. Well, Dr. Sachdev, thank you so much for your time. This was incredibly informative, and I think it was really helpful. Opportune September is PCOS Awareness Month, so I think this was just a fantastic conversation to have.
Well, thank you for having me. I really appreciated you giving me the opportunity to talk about something that's so important, especially during PCOS month. So I appreciate it. Thank you very much.
Thank you, everybody else, for joining us today. And again, if you're interested in UVA, check us out at uva.life. We do have a 15% discount for all of our attendees on your purchase. Just use the code PCOS event and you can get that. We'll also be sharing a recording of this event either later tonight or early tomorrow. So thank you so much for joining.
Thank you.
Bye, everyone.
Bye.